Ok, puoi andare.
Hello and welcome to all to this webinar on shifting lenses within emergency and trauma, the field experiences of the NGO Emergency and its psychological support unit in Italy, which is hosted by APA Division 52 International Psychology. And this webinar is part of an ongoing series to celebrate activities of psychologists around the world and to provide useful information for international engagement and to encourage us to take a broad and global perspective. My name is Pina Marsico, and I, along with Luca Tateo, are your co-hosts for today's webinar. And we want to thank the other member of the webinar committee, Dr. Falu Rami, Dr. Karen Brown, Dr. Mary Bullock, and Daniel Balba. And before we begin, our online audience have the ability to ask questions by typing them in the chat box. Please feel free to type your question during the presentation. Luca will be making note of them. And during the last 10-12 minutes, Luca will present them to our speaker. At this time, I will introduce and welcome our guest speaker, Alessandro Di Benedetto, who will present on behalf of Emergency Unit, which is a larger team of psychologists. It includes Dr. Bianco, Dr. Serri, Dr. Patara, among others. And Emergency Psychological Support Unit was established in 2016 as an integral part of the medical response provided by the organization to migrants arriving in Italy via the Mediterranean route. The psychologists offered primary assistance and were essential to allow for early identification of vulnerable cases in need of further support. Most of the cases concerned extreme vulnerabilities, and key beneficiaries included women, family groups, and unaccompanied minors. The unit of experts has further expanded its reach and operated in other 5 areas of Italy, providing assistance to migrants in emergency response contexts. Since 2017, the unit has also worked in regions of central Italy affected by an earthquake, which caused significant lasting damage to areas and its population. So the floor is yours, Alessandro.
So thank you, Pina and Luca. We really appreciated your invitation for this webinar. And good morning, everybody. Thank you indeed for your interest in our organization. I'm honored and at the same time, I'm excited to share with you our experience in emergency NGO. First of all, I would like to introduce one more time to my colleagues, the other members of our team. Laura Serri is the lead coordinator of the psychological unit. Giovanna and Serena are the 2 psychotherapists which providing psychological support to the population affected by the earthquake in central Italy. And me, I'm Alessandro Di Benedetto. I'm a psychotherapist. I'm working in Sicily, the most beautiful island in the Mediterranean Sea. And with Emergency, we are trying to guarantee psychological support and medical assistance to the population employed in agriculture environment, the farm workers, migrant farm workers in the Fascia Trasformata area. Let me start our presentation telling you something about the history of Emergency NGO. It started in 1994 in Milan, and it is an humanitarian organization founded to help civilian victims of war and poverty. Since then, we have worked in 18 countries, building hospitals, surgical centers, rehabilitation centers, a maternity centers in Afghanistan, a cardiac center in South Sudan. At the request of local authorities and organization, we also contributed to restructuring and strengthening of existing health facilities. Our first project was in Rwanda, where we were restructured and reopened the surgery ward of a hospital in Kigali, as well as developing the obstetrics and gynecology wards. One of the first things we did was the launch of a campaign that resulted in Italy banned the production of anti-personnel mines. Our doctors and surgeons have seen and continue to see the horror of the war and its effects. That's why we were compelled to advocate for peace, solidarity, and respect for human rights. So emergency promotes the culture of peace. In the meantime, we continue our work to provide free, quality care to those who need it. So victims of landmines, of war, but also of the poverty that results from war and which often compromises an entire country, sometimes even years after the end of the conflict. In 2018, we developed together with a number of African countries the manifesto for the human rights-based medicine to advocate for healthcare based on equality, quality, and social responsibility. So we declare the right to be treated as a fundamental right of every human person, of every member of a human family. So we believe that medical treatment is a fundamental human right and must be available to everyone. For medical care to be truly accessible, it has to be free of charge. And for it to be effective, it has to be of excellent quality. The latest hospital we opened was this month in Uganda. We opened a pediatric center, a center of excellence, pediatric centers in Uganda on the bank of Lake Victoria. We should have opened last year, but due to the COVID-19 pandemic that struck all the world, it forced us to rethink all our activities. Now, I would like to focus my attention at this presentation on our intervention in Italy, starting reminding us what the Italian Constitution establishes, says at the Article 32. The Republic protects health as a fundamental right of the individual and in the interest of the community, and guarantees free treatment to the destitute. Yet in practice, this right is often overlooked. Migrants, foreigners, poor people, often they don't have access to care because they are not aware of their rights. Sometimes they have linguistic difficulties and they are not able to navigate in the complex health system. It is because we were aware of this, and we had the desire to ensure the right of health care for everyone, even in our own country. That's our program in Italy was born. How we offer this kind of primary health care by offering free social and healthcare services, as well as orientation, the services of the NHS, considerably reducing the improper use of the aid department, collaborating with local authorities and local services to facilitate access to services, implementing pathways for taking care of disadvantaged patients in compliance with true equity, and therefore emphasizing the role of first-level social medical facilities. At the end, pursuing advocative and legal action for the recognition of the right to care. Sometimes poor people, but migrants, find three types of barriers: financial barriers, cultural and linguistic barriers, administrative barriers. For those, emergency found a solution. So emergency offers gratuity health primary care, so free of charge, as I told you before. And in our staff, we have many cultural mediators who help us in our project with migrants. And for the administrative barriers, we try to give a solution, for example, for the migrants who have problem with residence permit or the request of protection, humanitarian protection or international protection. In Italy, we work with, we have fixed clinics, mobile clinics, and street units. Till December 2018, we were working in the first reception center with migrants. After the disembarkation at the port, migrants will be recovered in first reception camp or first reception centers. And since the last year, 2020, we start a collaboration with Proactivia Open Arms, and actually we are working in a search and rescue zone. In 2013, we started working in different Sicilian ports, including Augusta and Pozzallo, offering primary care to migrants upon their arrival. To respond to these needs, in 2016, we began a project dedicated to providing primary psychological assistance aimed at more vulnerable patients, such as unaccompanied minors who have suffered torture or violence. Over time, interventions in the psychological field have changed and transformed to the need encountered by those frequenting the mobile or fixed clinics of Programma Italia. So we work, actually we work with migrants and vulnerable people by both fixed clinics. For example, in Marghera, is a town close Venice. in Naples, in Milan, and South Italy, in Polistena, is in Calabria region, and mobile clinics in Ragusa, in Sicily, where I'm living. Natural disasters, emergencies, and post-recovery, for example, in central Italy, with the population affected by earthquake in Abruzzo and in Marche region. For people who was infected or during the COVID-19 pandemic, all projects of Italy program are working with. During the disembarkations at the ports and the first recovery in the first reception centers, we provide first psychological support, early identification of vulnerable cases, minors, unaccompanied minors, or women who were abused, and follow-up meetings in the center, in the reception centers, where migrants were transferred from the port to temporary reception facilities. These are two pictures at the port of Augusta. On the right, you can see my colleague Valentina is a psychologist too. In order to help the most vulnerable members of the population and facilitating their access to the medical treatment, we have opened a mobile clinic in the province of Ragusa in Sicily, in the area referred fascia trasformata, transformed strip, due to almost uninterrupted all over 90 kilometers dedicated to greenhouses cultivation. So agriculture work in Ragusa is no longer seasonal, but takes place all year round. This means an increased number of agriculture workers, farm workers, mostly from Morocco, Tunisia, Albania, Romania, and their working and living condition are precarious. They work around 10-12 hours a day in a suffocating heat, and most of them live in abandoned houses, informal settlements, without drinking water, and in many cases without bathroom facilities. Our mobile clinics, you can see in the picture, this is our minivan, our mobile clinics, offers free basic medicine, sanitary education, social medical assistance, and psychological support. Our activities take place in the afternoon from 4 p.m. to 9:30 p.m. because in the morning migrants work in the land and the farm. Our patients so far have been affected mainly by joint and muscles pain, toothache, alcohol addiction. And the project is being carried out in cooperation with the health authority of the provincia of Ragusa. This is the other sector, the other intervention of emergency with migrants. In a context where there is no common European rescue intervention at sea, the presence of NGO vessels is essential to save humans and to rescue hundreds of people who undertake this dangerous journey to flee from violence and poverty. Just today, more than 100 asylum seekers feared death after their rubble boat capsized in the stormy seas of the coast of Libya. So it is for this reason that we decide to collaborate with Proactivia Open Arms and empty our medical personnel on board their search and rescue vessels. In August 2019, I was on board for 20 days. I was on board of Open Arms, and I provided consultation, and I tried to help the migrants before the disembarkation. We stayed 20 days on board waiting for the disembarkation. You can imagine what does it mean for people who had passed through the Mediterranean Sea, through the detention camps in Libya. The other intervention is in the urban centers and the peripheries in the urban centers. So, for example, in Milan, in Naples, and the intervention is implemented in several Italian cities. The population referring to the clinics is similar in terms of both medical and psychological problems. And we have volunteers and also medical doctor and nurses. They provide psychological support, medical care, and social medical assistance. The setting, emergency works with two kinds of setting, structured and destructured. Structured, for example, inside in the fixed clinics or inside the mobile clinics. When I say destructured, I mean, for example, sometimes for the first contact, the first meeting or the first consultation, I used to stay outside the minivan, sitting on a chair close to the minivan or under a palm tree and have an informal consultation. After this, I try to find a space inside the minivan in order to respect the privacy of the patient. In this picture, you can see the poly truck along the street in the center of in the peripheries of Milan. The fourth intervention is in the central Italy, in Marche and in Abruzzo regions, to the population affected by the earthquake. Other intervention is providing the nursing assistance for the population, for this kind of population in central Italy. Since the summer of 2016, central Italy has been hit by repeated earthquakes and aftershocks. In the subsequent month, weather conditions have further damaged an area that had already been left in dire condition by the earthquake, making daily life very difficult for the population, and not only in mountain villages. Even in the last few months, several new shocks were recorded. Our team, consisting in of a psychologist, a nurse, and a logistician, provides free assistance where health services cannot cope. So the project operates in the mountain area characterized by small and isolated mountain villages. This area have been massively plagued by repeated seismic swarm of high intensity, causing numerous victims and the destruction of homes, workplaces, churches, cultural heritage, and public places, meeting points. So this population have multiple needs. In the initial phase of the emergence, it was essential to intervene about the traumatic experiences resulting from the calamitous event and reduce the symptoms associated with post-traumatic stress disorder. Anxiety disorders are frequently observed. In particular, panic disorder, insomnia, and mood disorders. In addition to the symptoms, the population expresses a need for closeness and proximity, which can be observed also outside the therapeutic setting by the individual storytelling. The need to share, to tell what was there and what has been lost, building such a community memory is very, very frequent. In Marche region, one of the Italian regions, we launched a psychological support service and intended for medical staff from the hospital, cured or discharged former coronavirus patients, families of people and of still in hospital, and anyone who has lost a loved one to the virus. The service runs from our mobile clinic at the COVID-19 hospital in Camerino. Camerino is a town in Marche region. The service was run in collaboration with the national, the region health system. Furthermore, we are still providing psychological support and nursing for locals in the areas of the province of Macerata hit by the earthquake. The particular needs of the population allowed in an evolution of the psychological practice that is expressed in the deconstruction of the setting, in the use of an informal language, which often mitigates the sense of distract towards that other. So the psychological consequence and repercussions on the psychological well-being of the population are significant, and the stressful factors are numerous and repeated over. So this population had seismic events from 2009 to 2017. The exceptional snowfall of 2017, The current pandemic situation from SARS-CoV-2 has exacerbated the pre-existing symptoms and generated new suffering, so give birth a new psychological emergency. So emergency and emergency, emergency plus emergency. The economy crisis following the earthquake and the pandemic favored the phenomenon of the depopulation, which contributes to the loss of sense of identity, so both for the person and the community. So all these elements mutually influence each other, generating a vicious circle that maintains itself and strengthens over time. So the COVID-19 pandemics fits into the environmental framework connected to the seismic events of 2016, the snowfall of 2017, and the public and the private reconstruction that is struggling to restart. So it is important. Emergency was working since 2016, started to work in this region, but now with the pandemics, the situation is more, there are many people, vulnerable people. If you read the papers, every day we read people who had suicide themselves. In the theoretical framework of disaster risk reduction, we speak of black swan. So that it means high impact, event rare and difficult to predict, and gray rhino, so critical event very likely, despite this ignored. So the endogenous and exogenous factors determine a context of vulnerability. So hazard plus vulnerability equal disasters. So since the pandemic emergency has made available to the health authorities the skills of managing patients in the event pandemic, for example, emergency worked in Sierra Leone in 2014, 2015, so during the Ebola pandemic, so activating various dedicated projects throughout the country, so where it continued to work in fixed and mobile clinics in Italy. So the area affected by the 2016 earthquake of the Marche side is strongly affected by the first wave of the pandemic, and the hospital and the territorial units was being converted to cope with the growing number of hospitalizations in intensive care. So it was an emergency in an emergency. So both from a structural and a psychological point of view. So the ordinary activity continued in unprecedented extraordinariness, and it was joined by the request by the regional health authorities. So emergency activated a psychological support project ad hoc for the COVID emergency in favor of patients, family health personnel at the Camerino Hospital, which in full pandemic emergency has seen its conversion from the only hospital in the area to hospital COVID. In this slide, you can see the psychological emergence of the COVID-19 pandemic, and we talk about triage laico or lay triage. Lay triage normally when a patient comes in our mobile clinic or in our fixed clinic, there is a nurse who does the triage. So it is the first step, is the triage nurse for the evaluation of the patient symptom quickly, make a first assessment. During the pandemic, when the nurse was not available, the psychologists, me and Serena and Giovanna and Laura, did the triage, asking, for example, to the patient if he has some of a wide range of symptoms of coronavirus, for example, sore throat, headache, temperature, and in order to provide a psychological consultation in safety. So we check the temperature of the patient, invite him to wash his hand. We sit at the safety distance wearing the mask. If the patient was infected by coronavirus and stayed at home, we used to call him, and it is the first time we started to use to provide consultation by phone on Skype. So we call in order to monitor, to make a monitorization of the health condition of the patient. In this slide, you can watch so the definition of the health for the World Health Organization. Health is a state of complex or complete physical, mental, and social well-being, and not simply the absence of illness or infirmity. So you can read also keywords. So psychology of health, outreach, multidisciplinary equipe, systematic model dialogical, and epoche phenomenology. With the term psychology of health, we want to refer to all those health prevention and promotion activities. For example, identification of behavior relevant to risk and self-protective behaviors, or for example, coping strategies and psychosocial resources, or the promotion of appropriate health and lifestyles. With the term outreach, for example, outreach is the operation in general and the street work in particular that make a revolution in the social action, because it is not the person, the patient who reaches the service anymore, but it is the service to go to the person, meeting her in her place of life, often places of marginality and discomfort. So the outreach for us, for example, for organization which work in the field, outreach is one of the important action. When we say multidisciplinary equipe, we want to, I mean, there are several operators in our clinics. So you can find doctors, nurses, cultural and linguistic mediators, psychologists, logistics. So in our work, in our psychological support, for example, with migrants, cultural and linguistic mediator play a key role. The mediator is not just a translator. For me, for example, I used to work with migrants. The cultural mediator helps me to comprehend the anthropology and the culture of the migrants, and sometimes the different symptoms of the cultural bound syndrome. Okay, so it is important, the mediator in our job, in our work, in our psychological work. When we say systematic model, the psychologist, we mean the psychologist works in constant dialogue with the various actors in the health and the social system, so offering and sharing good practices. The psychology wants to be an added value to the complex treatment system. So the last word I would like to explain is epoche. Epoche is a Greek word. So the term epoche means abstention, suspension of the judgment. So the opposite notion could be identified with the term prejudice. As a psychologist, we believe we are supposed to welcome every person and whatever he shares with us, suspending every type of judgment. So in emergency NGO, we used to say no one is excluded from our care. Victim or persecutor, black or white, Hebrew or Christian, no one is excluded. Our intervention model is in two steps. In the emergency situation is the first step, and we provide the first psychological aid, identification of vulnerable patients, stabilization of symptoms, creation of a safe environmental context, psychoeducation, and training for bodies, institutions, and associations. This is our model for intervention in emergency. In the post-recovery, we provide counseling and psychological support, psychodiagnostic interviewing, clinical psychological interviewing, individual, couple, family, psychoeducation, support to self, also as for the emergency step, training for bodies, institutions, and associations. Network approach it means we work in collaboration with the region system to the national health system. So sometimes I have to send to a psychotherapist or psychiatric of the national health system, a patient I met, or to the local authorities, for example, CERT. CERT is an office for people who are drug addicted or alcoholic addicted. So we are in network. Our approach is network approach, so systemic approach. Yes, 2 minutes more. And our methodology, so is a bottom up. So we work. We decide to open a counseling center after listening to the needs of the territory. Then we start a time of evaluation and assessment in order to have a complete knowledge of the services present in the territory. So according a model bottom-up, we have an approach tailor-made, and we build our intervention. Furthermore, the pandemic has introduced another type of setting never experienced, as I told you before, in our field intervention of remote interviews through tools such as telephone, mobile phone, Skype, in order to monitor their health conditions. And finally, staff training. So for emergency, it is important that psychologists work in emergency and committed to our projects. Also, the voluntary psychologist must also be psychotherapist, and in continuing vocational training, and in to be supervised by our coordinator, Laura, for example. The psychotherapist has to be well trained because the system into which it takes action is complex and destructured. Last slide. Other words. Specific characteristics of interventions. So our intervention is characterized by some specificity. Easy access. So when we say direct, means easy access from the patients to our services. Capillary, the widespread coverage of the territory through our means, so we can reach the population living in remote areas. And so for this, we are in proximity to the population, and gratuity, you know, free of charge. So we provide healthcare free of charge. So during this year, from 2016 up to date, we met and we provide consultation to 1,412 people, and we provide consultation 7,124 consultation. In this slide, you can see the main diagnosis from 2018. This is our bibliography. If you want to have a deepened knowledge of emergency, you can contact our secretary or can have a look in our website. So thank you for your attention. Please forgive me for my accent because I don't practice often English, but I hope you understand what I told you, I shared with you. Thank you.
Well, thank you very much, Alessandro, for this very interesting and rich presentation. Well, we have now sometimes left for a few questions. I will take questions from the Zoom chat and from the the audience on the YouTube streaming. So, well, I will probably read the first question, which is, well, actually, this is a question of interest for a lot of our participants, is how do you become how a psychologist get involved in this kind of work? So how do you become an emergency psychologist, and what kind of professional trajectory, and also what kind of human characteristics, in a certain sense, one should have to do this kind of psychological work?
So my history is particular because I was involved with religious church, and I worked in the past also in Africa, and as a in a mission in Congo and Mozambique. So I found in emergency a way to be in mission. So when there was the emergency of the migrants in Sicily, Emergencies NGO opened a vacancy for a psychologist in order to work in the at the port during the disembarkations. So I applied. And there was a selection and emergency between the other participant choose me because I was working at the same time in a first reception camp. So I was a psychologist, I was a psychotherapist, but at the same time my specific main of interest was the migrants and the immigration field. So it is important to feel your habit in your body. So because working in the field, working in a NGO, so in a human organization, is different to work in a structured setting. For example, working in a clinic with patient who needs consultation because they have panic attack or depression, or is different. So sometimes emergency calls you, you have to be available to move from Sicily to region, to market region, or sometimes can ask you, for example, go to on board open arms because we need your you work for during summertime. So it's for this. It's not difficult, but if you visit our website, sometimes you can find our application, and if you are interested, everyone can apply. Okay. I hope I answered and I was exhaustive in my answer.
Thank you. Well, actually, we have a question related to this. And the question is how to cultivate the humanity of a therapist. I imagine that it means in this kind of situations.
It is not easy because sometimes you have you must create a distance because it's protective for yourself, because you stay with, you work with people affected by trauma, and the trauma infected also you, because sometimes you feel sad or you are hungry because, for example, you are talking with a woman abused. And it's not easy, no, because sometimes you have to create a space to be in empathetic, At the same time, you have to be aware in order to help the person. So I think after many years, you can start to work freely. But at the beginning, it is not easy. And for this, we have a supervisor. In this case, is Laura Serri, is our lead coordinator, and we often we have a chat with her, and we share, our feeling after, for example, a consultation, a dramatic consultation. So it is important for this.
Thank you very much. If the other member of the team want to say something, please just jump in. Actually, we have time for maybe one or two more questions. So one question is, have you ever, in which kind of dilemmatic situation or which kind of dilemmas have you faced? In which kind of dilemmatic situation have you been in during your work?
So at the port, when we were working at the port during the disembarkations, it was dramatic situations, because many people sometimes arriving died, not only still in life. So, or for example, stay on board in the Proactiva Open Arms was also for me impressive, and I was sometimes I think I was also a little bit traumatized, because you see many situations, you see the eyes of people was and have the signs of tortures and violence in their bodies. So it is sometimes you cannot dream, sleep, because you always think the stories they tell you. I don't remember a specific. Maybe a woman, Mariam, called Mariam. Yes, in this moment I have. I remember Mariam was a woman, was tortured and abused in the detention camp in Libya, and she was pregnant by her, how do we say, violentatore, abuser,
yeah, right,
abuser. Yeah. And she asked me the interruption, the pregnancy. So for me it was real moment, very stressful. So I remember this.
Okay. We have time just for a last quick question, and the question is, that's another interesting question, I think. What is when a mother is arriving, for instance, is rescued on a boat, on a rescue? What is the first thing, for instance, that she asks? Or the first kind of
a mother?
Yeah. I assume that the question is about a mother with a baby, probably.
Ask a safe place. A safe place. You have to give them, to give her a sense of safety, because during last 1 year or 2 years, they started their journey, and they pass through the detention camp, the Black Mediterranean Sea, that it is a beautiful sea, but in this moment it became asymmetry. So when it arrives, they ask, yes, a safe place, take a shower, sleep in a bed, in a normal bed, and starting a new life. So to have a new perspective. As a psychologist, we are the window of the future, in the future. So they start a new life, and we are the main through our words, our work, we give the future.
Thank you. It's an enormous responsibility,
Yes.
indeed.
I know.
Okay, so thank you very much, Alessandro. We are running out of time. Thank to all the emergency staff who collaborated in this webinar, and thanks to you all for participating, both on Zoom and on YouTube streaming. Actually, we would love to hear from you in the audience about this webinar. So please provide feedback on your experience about both the content and format of today's discussion. And I just want to, on behalf of the Division 52 Webinar Committee, I just want to wish you to enjoy the rest of your day and also the upcoming weekend, and see you back on the next event. Thank you again for Emergency.
Bye.
Thank you very much. Bye.